Good evening and welcome to our third session of our virtual patient education series, 2020 New and Emerging Treatments for Blood Cancers, with tonight's focus on MDS and AML. My name is Carrie Callis and I'm the program director here at the Leukemia Research Foundation. We're pleased to present this event in partnership with the Cardinal Bernardine Cancer Center at Loyola, and are grateful to have our presenters this evening, Dr. Khan and Dr. Dinner. We would also like to thank our supporters of this evening's program, AbbVie Jazz Pharmaceuticals, Karyopharm Therapeutics, and Novartis Oncology. As a brief background about the Leukemia Research Foundation, the Foundation's mission is to conquer all blood cancers by funding research into their causes and cures, and enriching the quality of life of those touched by these diseases. Since its inception in 1946, the Foundation has raised funds to award over $80 million of research grants to over 500 new investigators on 5 continents, and supports patients and families living with a blood cancer diagnosis through educational and support programs. I encourage you to visit our website, allbloodcancers.org, to learn more about our patient support programs, including our patient grant program, our online support community, and our comprehensive listing of resources. So at this time, I would like to introduce our moderator of tonight's program, Dr. Patrick Stiff, who is the director at the Cardinal Bernardine Cancer Center at Loyola. Dr. Stiff is the chair of the Foundation's Medical Advisory Board, and we thank him for all he does to advise and support our work at the Foundation. So turning it over to you, Dr. Stiff.
Good morning, good evening, I should say. Don't know what time of day it is sometimes, and I hope everybody can hear me as well. So welcome to all of you. This is the third and final event. It's not a debate. Sorry if those of you were tuning in hope to have a debate. We're going to have answers is what we're going to have tonight. The first of the 3 sessions focused on myeloma and mature B-cell neoplasms. The second one on large cell and other non-Hodgkin's lymphomas. Tonight we're going to focus on myeloid disorders, or diseases that involve the bone marrow of the myeloid lineage, which are the white cells, not the lymphocytes, neutrophils, blasts, if you will. So acute myeloid leukemia and myelodysplastic syndrome, which for a time we called pre-leukemia because many patients ultimately transformed into acute leukemia. Again, we're going to have 2 20-minute presentations, and then we're going to answer questions for about 30 to 40 minutes after the end of both presentations. So we're going to answer again questions after both presentations are done. So we're going to run right through them one after the other. Again, I'd like to thank the Leukemia Research Foundation for sponsoring this. Patient information is a win-win. It's a win for patients. It's also a win for us because the more patients are educated, the more they'll be able to make informed decisions about which treatments are going to be appropriate for them, which treatments are going to be the best for them. And if they know more about the treatments before they come in to see us, they'll be able to say whether or not they're able to follow or tolerate a specific therapy because they'll know something about it. They'll know about the options. We used to call this the Treatment Options Conference. And certainly, again, you're going to hear a lot of options. What's really exciting over the last year and two has been the rapid advances in the management of patients with leukemias and lymphomas. Those of you who keep up with this are amazed, as we are, by the number of new drugs, new treatments that have been available for treatment of these disorders. I think there's been a couple new treatments just for myelodysplastic syndrome approved within the last year. And unfortunately, one of the big trials turned out to be a negative trial looking at alternate agents. But again, it's an exciting time because we are seeing some progress. We know more about the genetics of these diseases and are focusing on what we can do to mitigate the toxicity of these diseases, as well as the toxicity of the traditional chemotherapy that we've given for the last 40 years. Dr. Shira Dinner is a leukemia specialist at Northwestern Memorial Hospital here in Chicago. She focuses on acute leukemias, and actually she's known nationally for her work in acute lymphoid leukemia. It's a much less common leukemia, but she's developed a unique expertise and will be leading an upcoming national trial in this space. She, again, is at Northwestern, and I hope that we'll be able to be enlightened quickly by her expertise.
Thank you, Dr. Stiff, for the introduction and to the LRF for hosting this. So tonight I'm going to talk to you guys a little bit about new treatments for acute myeloid leukemia. So first, just some objectives that I hope to achieve for you: to define terminology that's commonly used in acute leukemia, some background on what AML is, to discuss some newly approved drugs for the treatment of AML in the last few years, and to identify strategies for optimal patient care. What's the best treatment for you, and should you consider a clinical trial? So first, some common terminology in leukemia. So we often talk about the difference between acute and chronic leukemia. So an acute leukemia typically develops from immature cells in the bone marrow that are called blast cells that do not function normally. The blasts replicate quickly and aggressively. They're what we would call clonal, meaning they're all the same, and they are overproducing themselves and not dying off like they should, since they're abnormal cells. The cells do not grow up into mature white cells, red cells, or platelets as we would expect them to, so they can't perform their normal function in the body, things like fighting infection, carrying oxygen to your organs, or preventing you from bleeding. In chronic leukemias, they can develop from an immature cell. Things like myelodysplastic syndrome is typically more chronic, but it can have blast cells, or more commonly mature cells, like we would see in a chronic lymphocytic leukemia or a chronic myeloid leukemia. But still, these cells do not function normally. These are clonal, abnormal cells that are reproducing and taking up space and resources in the bone marrow, and typically they progress more slowly in the chronic setting. So other things we need to consider is a complete remission. This is typically our goal when treating you. This would be absence of any signs of disease, and also less than 5% blasts in the bone marrow when we look through the microscope, and then no evidence of leukemia anywhere outside of the bone marrow as well. We now, these days, also think about minimal residual disease. This is a more common concept in acute lymphoblastic leukemia, but is sort of a hot topic in AML as well now. It's a very low level of leukemia cells, so less than 5% blasts, but they're still in the bone marrow, and we can't see them by the microscope. We could detect them by either following certain gene or chromosome mutations in your leukemia, or by looking at certain antigens, which are proteins on the surface of leukemia cells. We also worry about refractory disease, which is leukemia that's not responding to the treatment or did not achieve a complete remission, and then relapse disease, which means leukemia that was in complete remission but now has come back. And finally, what's our goal with clinical trials? So we're often talking about things like overall survival, which is the length of time from either the date of diagnosis of the leukemia or the start of treatment for a disease that patients are still alive. So in a clinical trial, this is a very meaningful measure of success because it tells us how well the treatment's working. We're not only getting you into remission, but are you living longer with that remission? And then progression-free survival is the length of time during and after the treatment of disease that the disease remains in remission and the leukemia does not come back or get worse. So what exactly is AML? It's an acute leukemia that's developing from myeloid blasts in the bone marrow, which I'll show you a little bit more of in the next slide. The blasts take over the bone marrow and prevent it from doing its job, as I had mentioned previously. So normally your bone marrow should make white cells, red cells, or platelets, and it just doesn't have the ability to do that because it's making these abnormal cells instead. So patients can ultimately have these complications of infection, anemia, and bleeding. But the important thing to keep in mind is getting a diagnosis of AML isn't the same for everyone. It's a very heterogeneous disease. We look at different chromosome and genetic changes that can make AML different for every patient. So the case at the bottom left is a 25-year-old who came in with low blood counts, large bruises, and bleeding issues, and was found to have a translocation between chromosomes 15 and 17. This is a very treatable form of leukemia called APL, and it's curable. The patient on the right is a 25-year-old, so same age, but is coming in with a high white blood cell count, increased growth of their gums, tumor lysis syndrome, normal chromosomes, but they have something called a FLT3 ITD mutation, and this can behave much more aggressively, has high rates of relapse and higher rates of death. So as you can see, two 25-year-olds with the same diagnosis of AML, they're still not the same. There are significant subtleties to their disease. So here's a chart that reviews what blood stem cells are and what they should become. On the right side, you can see that stem cells can become lymphoid stem cells, and then ultimately they're lymphocytes, which is a type of white blood cell to fight off infections. On the left, you'll see myeloid stem cells. These should become myeloblasts, which then become a neutrophil, which is pictured here. And they should also become red cells and platelets. But essentially what happens in AML is that your myeloid stem cell is stuck in this myeloblast phase, and it's copying itself inappropriately and proliferating and taking over space and resources in your bone marrow, so then you're not making your neutrophils, platelets, and your red cells. So in terms of the incidence of AML, it's the most common type of an acute leukemia that we see, and it's also really the most common leukemia that we see in the adult population. There are about 22,000 cases of it annually in the United States, and unfortunately 50% of those cases are going to end in death on an annual basis. As you can see, acute lymphoblastic leukemia to the left is much more common. There's only about 6,000 cases, and about 1,500 of them, or 25%, would end in death per year. And then a more chronic disease, chronic lymphocytic leukemia, while it has similar rates to AML of about 20,000, only about 4,000 or 5,000 of those patients are going to die from chronic lymphocytic leukemia per year. So it's a much more indolent and slow-moving or treatable disease. The 5-year survival for AML, unfortunately, can be poor. The median age when most patients are diagnosed is about 70 years old, and you can see in this graph here that patients between the ages of 65 to 74 have a 5-year survival of 12.5%, and those over the age of 75 have a survival of 2.6% at 5 years. So clearly there's room for improvement there for our patients. So what do we look at when making a treatment decision for you and talking to you about your prognosis? One of the important things we consider are chromosome changes. We categorize these chromosome changes into 3 different categories: favorable, intermediate, and unfavorable. So I'm not expecting you guys to know or memorize these chromosome changes, but I just want you to be aware that these are things that we keep in mind as your physicians, and that we have data that some treatments are going to be working better for some of these groups rather than others. Generally, favorable means it's better, or it's going to be less aggressive and more likely to respond to chemotherapy, whereas the unfavorable group tends to behave very aggressively, is more likely to be refractory to the chemotherapy or resistant, more likely to relapse, more likely to need something like a stem cell transplant for a cure. So these are just some graphs to illustrate the outcomes of the different chromosome risk groups. So as you can see, in terms of the incidence of relapse, the adverse risk group has a very high incidence. It's over 90%. Those in the intermediate risk group, it's about 65%, and those in the favorable risk group, it still is about 50%. In terms of overall survival, you can see the adverse risk group does poorly. Their survival at about 5 years is only 5%. In the intermediate risk group, that improves to about 25%. And then in the favorable risk group, we're at about 55%. The other thing we think about when considering your AML is certain gene mutations that can occur in AML. So I think of your chromosomes as a little bit like a roadmap for your body, and gene mutations are stops along the way on those chromosomes. Certain chromosome changes or breakage can result in mutations in genes, but sometimes also there can just be other changes that occur in the genes. We don't think that these changes in your chromosomes or your genes are things that you are typically born with. They're often things that you acquired during the course of your lifetime. But unfortunately, we do see them, and we think that they have roles in driving the leukemia and potentially have roles in prognosis and also treatments that might work for you. So on the right-hand side of the table, which lists some of the common gene mutations that we see in AML, and once again, not for the purpose of memorizing, but just so you guys can see them, and maybe one of these mutations has been identified for you by your physician at some point. It lists the overall frequency of these mutations. A FLT3 mutation is one of the most common at about 30% prevalence. And then this circle diagram on the left-hand side outlines for you some of the common mutations that we see in AML. And the length of the arc that's coming from it shows the frequency of those mutations that we see in AML, and then also the width of it is showing the frequency of other mutations that happen with it. So as I mentioned earlier, it's a heterogeneous disease. It's not the same for any two patients, and even for most patients, they might have more than one mutation. So even if we do give you a drug that targets the mutation, there could be another mutation that's also involved in driving the disease. So it is very complicated. So here in this table, I outline some of the more common mutations, what we know about their prognosis, and if we have any treatments that can target them. So the most common mutation we see is a FLT3 ITD mutation. It's present in about 30% of patients. It does have a negative prognostic impact, so meaning that it's worse for patients to have it. We do have two drugs that can target it, though, midostaurin and Guiltitinib. And there's also data that if you have a high level of the FLT3 mutation, that you could benefit from an allogeneic stem cell transplant when you're in your first remission. FLT3 TKD mutations is another variant of the FLT3 mutation. We don't know if it's a good or a bad thing necessarily. There's been inconsistent data in trials. We do have a drug called Guiltitinib that's approved for relapsed disease that has this mutation. NPM1 mutations are generally thought to have a more favorable or a good prognosis. Actually, we don't think there's a benefit from transplant for these patients because they can do so well just with chemotherapy. And patients over the age of 60 have been shown to benefit from conventional intensive chemotherapy if they have an NPM1 mutation. DNMT3A mutations can also be seen frequently in AML and MDS. The prognostic significance we don't know clearly about. Some studies have said good, some have said bad. We do know that higher doses of daunorubicin improve survival as compared with standard dose daunorubicin in patients with these mutations. And also there's data that things like azacitidine and decitabine can work well for patients with DNMT3A mutation. A CBP alpha mutation is considered to be a positive mutation. We don't have anything that specifically targets it, but it is generally thought to be very responsive to 7+3 chemotherapy and consolidation chemotherapy. And then IDH mutations, we have an IDH1 and an IDH2. Don't clearly know the prognosis, but we do have drugs that are FDA approved for it in both the frontline and relapse setting. As well, there is some laboratory data to suggest, as well as clinical data, that these patients respond well to something called BCL2 inhibition, which is what a drug called Venetoclax does. And then moving down to the bottom here, KIT mutations are thought to be more negative. They can be present in patients who have some chromosome changes like inversion 16 and translocation 821, which are usually favorable changes. However, if you do have a KIT mutation, that can somewhat negate those chromosome findings and make it a higher risk for relapse. And then finally, the P53 mutation, unfortunately, is a very aggressive mutation. Typically, P53 works to suppress tumors. But when it's mutated, it doesn't have that effect, and so the tumors can replicate in an uncontrolled fashion. So what have we accomplished for AML? How do we treat it in the last 40 years? So for a long time there, I didn't have a lot of good news to report to you. From 1973 to 2017, we didn't make a lot of progress. So 7+3 was accepted as the standard of care treatment in 1973. And in 1977, we decided that an allogeneic stem cell transplant also had benefit or survival advantage for patients when they got treated with it. And then finally, 40 years later, we identified several drugs that have been FDA approved in the last few years for AML, and I'm going to talk a little bit more about those next. So what are our general principles when approaching treating AML? So first of all, if we don't treat AML, it can be fatal for all patients. For some patients, if they're presenting with very aggressive disease and they've waited a long time before coming in to see the doctor, that could even be a matter of hours. For many patients, it's going to be days to months, just depending on how their disease is behaving. As I said earlier, it's a very heterogeneous or variable disease for patients, so it can behave differently for different patients. In terms of the goals, our hope is to achieve a complete remission and then ultimately to cure the disease. And while we have several new drug approvals, I would advocate that it's always important to discuss the possibilities of clinical trials with your physician, because while these are great new drugs, they're not perfect, and we do have room for improvement still. So first I wanted to talk a little bit about how we treat what we would call fit patients. These are patients who have good energy levels, they're eating well, and typically we would say that they could spend at least 50% of the day out of bed, up and active, maybe even doing things like light housework, just because going through an intensive induction chemotherapy like 7+3 can be quite exhausting, and there are a lot of complications associated with it as well. So we give the induction chemotherapy in order to achieve what we call an MRD negative remission. So we don't want to see that little bit of leukemia that's not visible through the microscope that we can detect through other means, such as genetic testing and flow cytometry. We also want to convert that remission into a long-term cure. So we do that by giving initial chemotherapy. People often ask, I got chemo, I got one cycle of chemo, I'm in remission, why do I need more? If we don't give you more, it's going to come back absolutely. And then for some patients, we need to consider an allogeneic stem cell transplant, or else there's a very high likelihood of relapse. So this is just to highlight the importance of minimal residual disease. So what you can see in the graph on the left is that the red line shows patients who have active AML, so meaning that it was refractory or didn't respond to treatment. The gray dotted line shows those who are MRD positive. So they are technically in a complete remission, but they do have a very low level of disease that we can detect. And unfortunately, as you're seeing, they do just as poorly as those who have active AML. If we look at this table on the right-hand side, you can see the 3-year overall survival is comparable between those who have an MRD positive remission and those who have active AML, only about 25% at best. And a 3-year progression-free survival, meaning timing until the leukemia comes back, of about 12%. So it's very important that we achieve a deep response. So what are some of the treatments that we can use? 7+3, as I said, in 1973 was the approved treatment, and we've made some strides since then. In 2017, the FDA approved a drug called Vyxeos. Vyxeos is for newly diagnosed therapy-related AML. This is a type of AML that developed because someone previously had radiation or a chemotherapy for a prior cancer, or rarely for some autoimmune diseases. Or AML with MDS-related changes, which is AML that arose from a prior myelodysplastic syndrome, or AML that might have been diagnosed as having MDS-related changes because of appearance of the shape and size of the cells under the microscope, or certain chromosome changes that we can see in MDS. So what Vyxeos does is it combines cytarabine and daunorubicin, which is the agents you would normally get in 7+3, but it's giving them in a single, what we call liposomal formulation. So that's essentially a fat bubble that's wrapping these two drugs up into one drug. And it's been shown that it might help these high-risk patients. Typically, patients with therapy-related AML and MDS-related changes can be very aggressive and don't respond well to 7+3. The median overall survival with Vyxeos was 9.56 months, compared to about 4 to 5 months with 7+3. And there were better outcomes also for those patients that achieved a complete remission with Vyxeos and went on to transplant, compared to those who achieved a CR with 7+3 and went on to transplant. So I think, this study didn't measure minimal residual disease, but I think it's touching on the importance of that minimal residual disease, and one could hypothesize that maybe patients were getting to be MRD negative with Vyxeos, and that's why they had a better response and ultimately better outcomes even with transplant. Side effects are pretty common to what we see with chemotherapy, including bleeding, fever, infection, nausea, vomiting, mucositis, which is breakdown of the lining of your mouth or your gut, diarrhea, and fatigue. Sorry, it doesn't look like my slides are advancing. Okay, there we go. So what do we consider as therapy for unfit AML patients that's sort of newly approved therapy? So our general goal is to try to also give an induction to achieve a remission. However, this is usually a less intensive treatment, and we acknowledge that we're probably not going to get to the point of cure. We call this a palliative treatment, meaning that it could get the leukemia into remission, it could prolong your overall life, but there's still a very high risk that the leukemia in the long term is going to come back. And so what we're aiming to do is to achieve a good quality of life and hopefully transfusion independence, meaning that you don't need blood or platelet transfusions, and hopefully that you're not neutropenic, so not at such high risk for infection. So one of the first drugs that was approved by the FDA was Guiltitinib. It's an inhibitor of something called Sonic Hedgehog, obviously not a video game character. In this case, it's a protein that's present at very high levels in many types of cancer. And so this drug is blocking or inhibiting that protein and then causing the cancer cell to die. The FDA approved this drug in 2018. It's an oral drug that's given by mouth daily, and it's given in combination with low-dose cytarabine injected under the skin twice daily for 10 days. It's specifically for newly diagnosed AML over the age of 75 who are unfit for chemotherapy. So they define that as having severe heart or coronary problems or coronary artery disease, kidney problems with a high creatinine, and a poor performance status. So meaning like you can't do things like get out of bed for more than 50% of your day. The median overall survival was 8.3 months, which was better than the control arm of low-dose cytarabine alone, which was only about 4 to 5 months. And the side effects were anemia, low platelets, fatigue, bleeding, fevers, muscle pain, anorexia, change in taste, mucositis, and rash. Now, at the same time, the FDA approved another drug for patients who are unfit for intensive chemo. This is called Venetoclax. Venetoclax works differently than Guiltitinib. It blocks something called anti-death B-cell lymphoma 2, or BCL2, which is a protein that's found in many cancer cells. And so as it describes itself in its name, it's an anti-death protein. And so blocking it, it causes the cell to die. And it's also approved for patients who have untreated AML, who are over the age of 75 or are not fit for intensive chemotherapy. Venetoclax with azacitidine or decitabine was studied in patients who had new AML, so no prior things like MDS. And Venetoclax with low-dose cytarabine also allowed patients with a history of MDS who had received prior treatment with azacitidine or decitabine. And they just did a phase 3 trial that looked at Venetoclax and azacitidine versus azacitidine alone, and it showed that those who got the Venetoclax with azacitidine did have a significant improvement. Their overall complete remission rate was 66%, and the median overall survival was 14.7 months, whereas it was less than 1 year with azacitidine alone. Side effects were nausea, low blood counts, fever, pneumonia, sepsis, and bleeding, and we definitely see that low blood counts are a big thing that can impact patients with this treatment. So, how would I as a clinician pick between Guiltitinib and Venetoclax in terms of treating you? Overall, I would say that the median overall survival was better with the Venetoclax and drugs like azacitidine or decitabine and low-dose cytarabine. So that would be my first choice, but we also do consider Guiltitinib as an option for patients, whether it's related to things like drug interactions, side effect profiles, or if you've had Venetoclax and things like azacitidine and you're progressing on that, we could consider Guiltitinib and low-dose cytarabine as another treatment option for you. So then there's also oral azacitidine, which was just approved in September for patients who are unfit for intensive chemotherapy. And you might say to me, well, why can't I get an all-oral regimen? Typically, azacitidine, decitabine, and low-dose cytarabine are either injections or they're IV infusions. So specifically, the way that oral azacitidine was studied is as a continued treatment of patients who achieved complete remission, initially with an intensive induction chemotherapy regimen, such as 7+3. But they weren't able to complete their intensive chemotherapy treatment because they weren't tolerating it well and they weren't fit to get more intensive treatment like high-dose cytarabine consolidation and a stem cell transplant. So it's approved as a maintenance therapy after getting into remission. The median overall survival with oral aza was 24.7 months compared to 14.8 months with placebo, so just observing patients and not doing more treatment. And the side effects were nausea, vomiting, diarrhea, fatigue, constipation, pneumonia, abdominal pain, arthralgia, decreased appetite, and neutropenic fever. And so the way it's generally recommended is to use after someone's already gotten into remission. So one could consider it in theory after you get into remission with something like IV azacitidine or decitabine and Venetoclax. However, I do caution you, and it's something you should talk to your doctor about, that oral azacitidine has not been studied with Venetoclax. So these two oral drugs could interfere with each other. One could affect the absorption of the other. It could increase the levels or decrease the levels. We don't have any data in terms of efficacy, so in terms of how it could impact survival outcomes, we just don't know that. So then moving on to more specific treatments that block particular mutations. The ones I presented to you just now were those that are kind of generally available to the AML population, but they don't focus on any particular mutation in AML. So first we'll talk a little bit about FLT3 and then move on to IDH mutated AML. So FLT3 mutations are present in about 30% of AML. And what I put here on the right-hand side is a little bit of a diagram of the FLT3 receptor. It's present on the surface of the AML cell. This little line with the yellow and blue is supposed to be the cell surface. And then you have a receptor that goes from the outside of the cell to the inside of the cell. And the mutation can occur here in this part of the receptor. And then basically it's like flipping a switch. It turns the receptor on and it's constantly signaling inside the cell that the cell should continue to live and it should proliferate or multiply. And so what midostaurin does, here it's represented here, it's right after the brand name for it, it blocks, it sort of binds to this part of the receptor and it blocks it from signaling and it causes the cell to die. So the FDA approved midostaurin in 2017 in combination with 7+3 for newly diagnosed FLT3 mutated AML. The median overall survival was remarkable at 74.7 months with midostaurin versus only 25 months with placebo or getting 7+3 alone. Side effects were neutropenic fever, nausea, mucositis, vomiting, and bleeding. So this is one of the first success stories in terms of it is an intensive treatment. But adding a molecularly targeted therapy to block a specific mutation to 7+3 and having a very significant survival benefit. So we were fortunate to have another drug called Guiltitinib approved for FLT3 mutated AML as well, just a year later in 2018. Guiltitinib is an oral drug that you would take by mouth continuously daily. It's given by itself, not in combination with chemotherapy at this time. It did have a complete remission rate of 34%, which is very good for this relapse population. They often don't respond very well to chemotherapy. 31% of patients became transfusion independent, and the median overall survival was 9.3 months. Side effects were muscle and bone ache, fatigue, and liver inflammation, not that patients felt, but that were noticed on blood work. And currently there are a lot of combination studies in process. So looking at Guiltitinib in combination with 7+3. As well as looking at Guiltitinib in combination with newer drugs, Venetoclax, for example, such that we can try to see, can we increase the efficacy of the Guiltitinib beyond that 34% remission rate and also hopefully improve the survival outcome. So then moving on to IDH mutations. So IDH mutations prevent the DNA from making genes that are important for myeloid stem cells to mature into functional adult blood cells. So when you block the IDH mutation, essentially it can allow those cells to go on and mature into those adult cells, things like white cells, red cells, and platelets. So in July of 2018, the FDA approved the IDH1 inhibitor, ivosidenib, which is an oral drug for relapsed refractory IDH1 mutated AML, had a complete response rate of 33%. The median time to response was 2 months, so about 2 cycles, and the median response duration was 8.2 months. 37% of patients became transfusion independent, and the side effects were fatigue, high white cell count, bone aches, nausea, diarrhea, constipation, swelling, mucositis, and changes in heart rhythm. There was also differentiation syndrome. And so what that is that when these cells are suddenly unlocked from being in a blast state and are maturing very quickly, and a lot of them become mature adult cells at the same time, can cause a lot of inflammation in the body. And that can result in some fluid in the lungs, some failure of the kidneys. And so it's very important that if you are on this drug, that you're monitored closely by your treating physician. They can do things like stop the drug or give you steroids in order to treat that. As well, in 2019, the FDA expanded their approval of ivosidenib for newly diagnosed IDH1 positive AML in older adults who are unfit for intensive chemotherapy. The complete remission rate was 43%, 41% became independent of transfusions, and currently there are studies of combinations going on, things like azacitidine and ivosidenib, or even azacitidine, venetoclax, and ivosidenib. So it is a nice all-oral option for some older adults who might not want to be getting an IV chemotherapy. In terms of IDH2 mutations, so in this case, an IDH2 mutation works the same way as an IDH1 mutation, and we have just a different drug to block it, Incidence. It was approved in 2017 by the FDA for relapsed refractory IDH2 mutated AML. It achieved a CR with or without count recovery in 23% of patients, and the duration of response was a median of 8.2 months, and the median time to best response was 3.7 months, and 34% no longer required transfusions. And the NCCN National Comprehensive Cancer Network does also recommend this as an option for frontline treatment of IDH2 mutated AML. So then finally, I want to talk to you a little bit about immunotherapies. I think this is perhaps where some of the newer AML treatments will move in the next few years. Something that's been around for about 10 years now is a drug called gemtuzumab ozogamicin. It was initially on the market and then was pulled from the market, but subsequent trials validated it and it was brought back in the last few years. It's an antibody against CD33 on the surface of the AML blast cell, and it's linked to a toxin. So this sort of Y shape here is your antibody, and then there's this linker protein, and then there is a toxin that's attached to it. So it binds to this CD33, this little orange circle on the surface of the AML cell. It gets taken into the cell. Some of the enzymes or the chemicals inside the cell degrade it and release toxin into the cell, and it kills the cell. So it's FDA approved for fit AML in combination with 7+3. It improved event-free survival to 17.3 months, in particular for patients who had favorable risk chromosome changes. It's also FDA approved for newly diagnosed elderly unfit AML. However, the median overall survival is short at 4.9 months, so I would say I would probably favor either Venetoclax with something like azacitidine or even Glasdegib with low-dose cytarabine over this. And then it's also FDA approved for relapsed or refractory AML. It had a 26% complete remission rate and 11.6 months relapse-free survival, so meaning the time until the disease came back. And currently additional immunotherapies are under investigation, in particular ones that not only use an antibody to bind to the surface of the leukemia cell, but are actually trying to do things to activate your immune system to attack the leukemia cell. And we do have clinical trials for that I can answer questions about if you're interested. So to conclude, what's the best treatment for you? Importantly, every case is different. As I discussed, there's a lot of chromosome changes, a lot of genetic changes that can distinguish your AML from another person's AML. You have to talk to your physician about these changes, these mutations, and to better understand what treatment might be best suited for you. One of the newly approved treatments might be right for you based on this available information that they get from your chromosomes or your genetics. And then I think it's always important to talk to your doctor about a clinical trial. First of all, the drugs we discussed today were approved based on very recent early phase clinical trials. So I want to emphasize that in terms of if you're afraid of the idea of a clinical trial. You're not just being a guinea pig. There is scientific rationale in terms of why they're investigating it. Many times there's even early phase clinical data for the drug, and never would they deprive you of getting treatment. So never are they going to give patients an absolute placebo. You would always be getting some sort of treatment. It might be a standard of care treatment, but it might also be a standard of care treatment with a novel or new drug added to it. And then also newly approved drugs are now in clinical trials in combination with other novel or experimental drugs that might improve their outcomes. So I would encourage you to consider it. And with that, I'll take any questions that you guys might have.
We are planning our annual town hall meeting, which is a Q&A style forum, kind of similar to what we had here at the very end of the program. So we will be sending all of you information about that as we have it together. It's scheduled for January 31st. So thank you all for joining us and have a wonderful evening.